Okay.
Thank
Okay,
you,
Nirmal
Kedar,
da,
for your kind.
floor is yours.
Yeah. Thank you, Kedar, for your kind introduction, and good evening to everyone. So I am Nirmal, as Kedar has already mentioned, and working as an assistant professor of respiratory medicine in the National Institute in Dhaka. Okay. So today I will talk on the basics of lung ultrasonography. So as Kedar has already told, why he asked me to get reading on this topic and deliver a lecture on the lung ultrasound. Just to pay my homage to my mentor and very good friend, Dr. K. So when I started IP training on 2020 under the mentorship of Kedar, when he gave me the assignment on talk on this thoracic ultrasonography, I asked him, why me? So he gave me the historical dialogue. Nirmal, if the others talks on thoracic ultrasonography, they will learn only for themselves. But if you learn the thoracic ultrasonography, you can teach 100 of your students. And that is why I'm working on lung ultrasonography. But I know very basics and very little on this topic. Okay, let's start. My today's point of discussion will be on the scopes of thoracic ultrasonography in pulmonary medicine and the basics of thoracic ultrasonography and the novology, manipulation of a machine, and the common mistakes we do while doing ultrasonography. Since its inception, the ultrasonography had the radiologists for their practice. But for the last few decades, there is gaining interest on ultrasonography for the application of this tool by the other disciplines. And keeping in pace with the others, the pulmonologists all over the world has started practice the thoracic ultrasonography for the diagnostic workup and invasive procedures. No doubt, the widespread use of thoracic ultrasonography as a point of care has significantly changed the respiratory and critical care practice. Henceforth, the competence in performing thoracic ultrasonography is now an obligatory part of pulmonology training all over the world. The compact design of the machine and extensive range of diagnostic capabilities has made it an indispensable tool for the diagnostic imaging. But why thoracic ultrasonography? We have chest X-ray, we have CT scan of chest, we have MRI. But why ultrasonography? Where it was commonly practiced for the diagnosis of abdominal pathologies? Just have a look at it. The advantages of over the other modalities is that it is relatively inexpensive, as the machine is portable. It allows the bedside examination. It is easy to handle, no radiation hazard, real-time point of care imaging is possible. And to some extent, it is superior to CT scan, especially in critically ill patients. Just have a look at this picture. The chest X-ray, you are seeing that on the left side, there is a small pleural effusion, and the right side is just blunted CP angle. But this patient, when we have done a CT, this patient has the moderate pleural effusion on the left side and small pleural effusion on the right side. But look at the sonography on the lower side, upper and the lower left. There is pleural effusion and this is the left-sided marginal effusion. There is also the thickening of the diaphragmatic pleura, and there is also the collapsed lung. So the thoracic ultrasonography can delineate a vivid picture of the pleural pathologies. The second picture you see, this is the another chest and chest sonography and CT scan of the chest. Here there is a marked pleural effusion on the right hemithorax, but when you do the ultrasonography of this patient, there is an extensive septation and the pleural thickening and loculated effusion. So if anyone jumps to do the pleurocentesis, just seeing the X-ray or CT scan, it is certain that he may miss the pleural fluid aspiration. So this is the strength of pleural ultrasonography to get a real-time picture to do the diagnosis and the intervention. So in pleural medicine, it supports the entire patient journey from the initial diagnosis to management and prognostication. It avoids the delay in the diagnosis. We can take a spot decision for the diagnosis and what to do next. It makes the journey plan and execute more advanced diagnostic and therapeutic interventions. By doing the thoracic ultrasonography, especially in effusion cases, we can detect, quantify, and characterize the pleural fluid. First of all, we can confirm whether the pleural fluid is real, that is, it is not a PF mimics. We can evaluate the size of the effusion and the diaphragmatic function. The character of the pleural fluid can be determined whether it is anechoic or echogenic, whether it is the simple or septate effusion. Pre-procedural probability of the suspected underlying pathologies, like that is whether it is a malignant effusion or infectious etiology. It guides outcome prediction of various interventions also. So while doing the procedures, we can plan a pre-procedural plan, that is which site is most suitable for doing the intervention. During procedure, the real-time image is possible, so we can make the intervention more easier and more safe. And after doing the procedure, whether there is an immediate complication, we can diagnose and detect by doing the ultrasonography and take the timely management. We can also assess the prognosis of a certain pathology by doing this thoracic ultrasonography. That is whether the patient will get symptomatic benefit. That is by identification of diaphragmatic flattening, inversion, or paradoxical movement. In case of non-expandable lungs, especially in case of malignant pleural effusion, which is the best possible option for the management of this malignant effusion, we can determine. And the success of pleurodesis can be determined by the identification of the early situation of lung sliding within the 24 hours of pleurodesis. Henceforth, the British Thoracic Society 2010 guideline has recommended the pleural ultrasonography a must-doing procedure before doing all the pleural procedures. Only for the pleural procedures or only for the pleural pathologies? No, it has a vast array of application beyond the lung and pleural. Just think about the extrathoracic lymph nodes, especially in the cervical lymph nodes. We can determine whether this is the malignant or a reactive lymph node. Just if you don't have an access to EVAS, if we can diagnose an supraclavicular lymph node, that is the entry lymph node, we can stage the patient. In case of the chest wall or skeletal pathology, any soft tissue mass, bony metastasis, and rib fractures can be detected. For the lung tumor, especially the peripheral located tumor, whether there is a chest wall invasion or involvement of the parietal pleura. So we are certain that this is the T4 disease. We can also diagnose a pulmonary consolidation and lung abscess. For the breathless patient, we can differentiate between the pulmonary edema and alveolo-interstitial syndrome from the obstructive airway diseases. In critical care practice, we can adjust the PEEP in atelectatic lung. We can guide CV line. It can guide the CV line placement and determine the proper positioning of endotracheal tube by doing a thoracic ultrasonography. We can also assess the diaphragmatic function by, in case of COPD patients, by seeing the diaphragmatic excursion. We can say that how severe is this the COPD, especially who can't go for the spirometric maneuvers. For the diaphragmatic palsy, we can detect the thickening fraction. So you have seen that in the pleural disease and beyond the pleura and lung, there is a vast application of thoracic ultrasonography. So just have a look for the basic physics of thoracic ultrasonography. Be aware that this is a bit monotonous, but to get deep into the topics, we have to learn the basics physics. So what is the sound wave? It is an energy, that's a sound energy that moves forward in an oscillatory fashion. Okay, it needs some media for propagation. Here you see this is the sinus type of wave. From the tip to the middle part, this is the amplitude. And the distance between the two tips is called the wavelength. The wavelength and the frequency of sound wave is inversely proportional. That is if the wave is long, and if it is short, the frequency is high. This is the basic, because we have to know these basic points. So the ultrasonic wave has a frequency of 2 to 20 megahertz, which is much greater than that of the audible sound wave. That is from the 20 hertz, 20 kilo. And sound wave is produced in the ultrasonic transducer. There is some crystals within the of the electrodes. There is a special type of crystals, and this is called the PZ crystal. When the sound wave is passed through the this transducer, there is movement of this PZ crystal and formation of the sound wave. When this sound wave is propagated, while the transducer is come in contact with the tissue, certain period it is reflected back and catched by this PZ crystal element. One important property of this PZ crystal is that while PZ crystal produces one sound wave, until this no news.
Nirmalda, can I interrupt you here?
Vital property of this PZ crystals.
Nirmalda, can you repeat this slide?
Back from this to the crystal. Yeah. Yes. Sorry. This one.
Nirmalda, your
line.
Yeah, we are losing you in between. So can you repeat this particular slide, please?
Okay. This slide. Okay. So the sound wave is produced by the agitation of PZ crystal or the piezoelectric crystals. So there is an important property of electric crystal. When a sound wave is produced by one single crystal, until and unless it is reflected back to that crystal, no new wave is produced by that particular crystal. Okay.
Yes, please go ahead.
So these are the different types. Yeah. Okay. So these are the different types of machines. And okay, this is very important. That is the knowledge. We have to have the knowledge of different knobs. In the immunologist, we don't have to know everything, but the very basics and the important knobs we have to know. This are the first one is this. This is the focus. That is the focus and depth knob, and this is the gain or brightness knob. This is the TGC or time gain compensation. These three knobs are very, very important. And another one is the aim mode button. This is the cursor. This is the calipers. Ultrasonography uses the real-time grayscale B mode. That is the brightness mode scanning. There are two different types of modes. There is the aim mode or motion mode and A or amplitude mode. But the amplitude mode is not used by us, but aim mode is important for the diagnosis of the pneumothorax. The key control can be adjusted in the following order. That is the first, the depth, then the focus, then the time gain compensation, and then the gain or brightness. Just have a look at each and every one. The depth and focus, what is this? The first, we have to choose a structure that we are going to examine. Then we have to adjust the focus for the best possible image, and it improves the lateral resolution. That is, what is the lateral resolution? This is the ability to separate the two adjacent structures in a given depth. Just think about a camera. When taking a picture, we first focus on a particular object and then we adjust it. Just same thing happens when I do the sonography for a particular organ, like liver, like spleen, like the diaphragm, or like any pleural pathology. We have to adjust the depth first, then the focus. And the next one is the TGC or time gain compensation. What is this? Just think, when the sound waves propagate forwards, the nearer structure is reflected first and then the furthest structure. So certainly the image that we get from the nearer structures is more brighter than the furthest structure. As a result, the furthest structure is just blurred. So the machine has a option for the amplification of the image of the furthest structures. This is called, this particular property is called the time gain compensation or TGC. And the TGC buttons are arranged diagonally. The upper buttons for the near structures and the lower button for the furthest structures. And this is when it moves from the left to the right, it becomes more bright. So before doing the sonography, we have to check for this TGC button whether it is rightly placed, especially the diagonal formation. What will happen if we change or if we don't use this TGC button diagonally? Just have a look at this video. So here I have put the TGC button for the nearer image further, so it is the more bright. Okay. And for the furthest structure, I put it in the lowest amplitude, so it is harsh. One thing you have to remember that the higher the frequency, the sound wave moves too fast and it is reflected back quickly. So by using the linear transducers, penetration is very poor. So it is suitable for the superficial structures like the skin lesion, like the chest wall tumors, like the lymph nodes, like the pleura, like the testis or subcutaneous tissue. And this is the rectangular image that we can get by using the linear probe. And this is the curvilinear probe or curvilinear transducers, the wide and fan image. As each version of these sound waves, and there is a better depth of penetration, but the resolution is relatively poor, and it is suitable for the pleural effusion, upper abdominal organs, and mediastinal structures, and it produces this like the fan-shaped image. Now, a few things we have to keep in mind. What is the what the sound waves do when it interacts with human body? There are the certain things like it reflection, transmission forward and attenuation, absorption, scattering, and refraction. Very important 2 or 3 things is the reflection and the attenuation. So when the sound waves comes in contact with human body, it moves forward, and after a certain time, it is reflected back. And this reflection depends on the acoustic impedance. What is the acoustic impedance? It is the nothing but the product of density of the medium and the velocity of the sound wave. The structure that have the higher acoustic impedance, their sound produce a brighter image, and the bone and ear and fluid has very poor acoustic impedance. It produces no. What is attenuation? Just think about it. When we throw a stone on a pond, the waves moves further, and after a certain time, it fades away. Just like sound, when it goes through the body or tissue, after a certain time, there is a loss of energy, and sound wave it is faded down. And it depends on the absorption of sound and scattering of the sound. It depends on the density of the material, density of transducer. For water, aqueous medium, it has least attenuation, and so water is a very good medium for acoustic window for the skin. And bone and lung has the highest attenuation, and it is responsible for the formation of various. The absorption is not important. Scattering and reflection, these things are not important. But artifact, you know that air is a very poor medium for the transmission of sound wave. When there is any pathology, like so as we know that the lung is alveoli is full of air, it is a very poor medium for the transmission of sound wave. When there is any pathology like pleural effusion, like consolidation or mass, artifacts help us to delineate, to diagnose a pathology. Two different types. There are different types of artifacts, but among them, 2 important artifacts, that is the reverberation artifact and cometal artifact, is very important for the diagnosis of different lung pathologies. The reverberation artifact, this is nothing but the reflection of sound wave. When the sound propagates forwards, it is reflected by the pleura air interface, and it is then reflected back, and it produces these types of parallel lines, equidistant parallel lines. The red circle, this is the pleura, and the parallel lines are the reverberation artifact. This is called the A lines. And the second one is important. This is the cometal artifacts, when this is the vertical line when air is transmitted back from a pleura, or there is interstitial edema or interstitial fluid. This is just like comet, so it is called the cometal artifact. It is a normal phenomenon, but if the cometal artifacts is more than 4 or 5 in a window, it is a pathological. Then we call it the B lines. So these are the so far the physiology and the sound waves and the common artifacts. And now let's start with the machine. So first, check the power supply of the ultrasound room and the ultrasound machine. Then select and connect the correct probe. For the superficial structures, as I have already mentioned, we will use the linear probe. For the deeper structures, we will use the curvilinear probe. Clean the probe before using. If there is any chance of contamination, you can cover the tip of the probe with any coverings like hand gloves or plastic. Okay, then check the things, that is the TGC I have already mentioned. This is very important because the previous examiner may do ultrasonography and change the TGC, and if you don't check this TGC setting and do an ultrasonography, if it is incorrect, it will take a false image. Correct the depth of and the focal zone, and the true gain shall be turned on. Review the patient's more recent X-ray and CT scan. Especially, it is important if you are intended to do any pleural procedure or any lung procedures. And it also make your time to consume your time. It make your examination tailored. The scanning environment is very important because you have to use the appropriate background and lighting. If there is any light, like any fluorescent light or the natural light, it should be covered any curtain and put off switch off all the lights. And the accessories should be kept in hand, like the gel, tissue paper, towel, and a skin marker. Equilateral triangle arrangement. Just have a look at this picture. This is the sonologist, this is the machine, and this is the patient. So this is a equilateral triangle. This is a very good ergonomic, and it will it is very good for the examination of both the patient and also seeing the monitor. Now, how will we keep the probe in our hand? It should be kept like a pencil, not like a knife. Just have a look at this. The main fingers are the thumb and the index fingers, and the rest of the fingers will touch the skin so that there is a support of the probe on the other fingers. Keep the anchoring contact between the operator's probe hand and patient's chest wall, and avoid marked angulation of the patient. It will make the procedure painful. And the areas of exploration, in case if the patient is ambulatory and if you are looking for the pleural effusion only, then you can examine the patient from the back, keeping the patient in the sitting position or a stool. Or if the patient is unconscious or less mobile, then you can do the procedure in the lateral decubitus position. Always keep in mind that a small change in position and the posture can radically improve the sonographic visualization. This is the area of exploration: the anterior superior, anterior inferior, lateral superior, lateral inferior, and posterior superior and posterior inferior. If we adopt the blue protocol, just have a look at this: the two hands on the chest wall, just index finger of the left hand just below and parallel to the clavicle, and the right hand just above the hand, and covering the thumb. The upper point is in the middle part of the left hand, and the lower point is the middle part of the right hand. This is the upper blue point, and this is the lower blue point. And if we make a line, horizontal line from the lower blue point to the posterior axillary line, this is the flaps point. So there are 3 points: upper blue point, lower blue point, right flap point, upper blue point, lower blue point on the left side, and the left flaps point. This is very good for the exploration of the whole chest without covering the that is heart. And all the 3 lobes or all the 3 zones of the lung can be explored. That is the upper lobe, middle lobe, and the lower lobe. This is the probe orientation. We can orient the probe. If we scan the posteriorly, this is the vertical orientation in the intercostal space, oblique or transverse, and this is the coronal orientation. So this is I am at the later part of this my presentations. So there are 2 or 3 slides. The common mistakes that we do the thoracic ultrasonography. The first is the poor preparation prior to the scanning without reviewing the current imaging. This is a big mistake and big blunder. Is not optimized. If there is a light on the it makes the image dark, and it's good ergonomics, that is the hand and transducer is very important. Poor patient positioning, you should avoid the poor patient positioning, because this is a real-time imaging, and the change of the positioning will greatly hamper the image quality. Lack of image optimization. Must use the systemic approach to ensure the diagnostic quality of image. As I have already mentioned, that is the depth, focus, TGC, and gain. Poor probe orientation and manipulation should be avoided. Lack of confidence in the identification of the hemidiaphragm. This is very important. On the right side, the liver and the right hemidiaphragm. On the left side, the spleen and left hemidiaphragm. Not scanning the anterior hemithorax or both sides. We just look at the only for the pathologists, like the right sided pleural effusion. We are seeing the pleural effusion, but we don't explore the whole chest on the right side or the left side. This should be avoided. Becoming too assured, that is the dilution of grandiosity. This is very important. So, and the protracted time between the ultrasonographic examination and the procedure. So you have done the sonography, you have marked the patient's skin, and you are doing the procedure in another room or after a later time. But by this time, there may be change in the position of the patient, and when you're doing the procedure, there may be mistaken to get the desired desired effect, and incorrect interpretation of the complex anatomy or pathology. Don't forget that you are not the only person. The radiologists are still there, and they are your colleagues. So get help from them if you can't understand any pathology. So this is my last slide. The thoracic ultrasonography, it is an art. It is not the single day's procedure. I always say that see one, do one, and teach one. It is wholly the responsibility of an operator who needs good eyes to correctly interpret an image, good hands to adequately guide the probe and create a good quality image, and a good mind who knows the pathology, understand the clinical situation of the patient, and integrate the clinical data with ultrasonography to obtain the final accurate diagnosis of the patient. So this is my last slide, and this is Professor Jose Chaco. Actually, this lecture was intended to be delivered by Professor Chaco, and I'm just making a proxy of Professor Chaco. And here, this is the end of the part 1. In the next class, I'll go to the pathological part of the thoracic ultrasonography and the image interpretation. Thank you very much. Thank you.